Hello, my name is Ashley Haller, and I am a research technician here at Resolve Manitoba. I'm very happy to welcome you all to our webinar, Traumatic Brain Injury and Intimate Partner Violence, Challenges for Survivors Involved in the Family Court System. Next slide, please. So before we get started here, I would like to recognize the land that we are meeting on today. I would specifically like to acknowledge that the Resolve Manitoba office and the University of Manitoba campuses are located on the original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on the territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. And of course, many of you may be joining us from other parts of Canada, so I invite everyone to acknowledge the traditional lands that they are gathered on today if they happen to be outside of this territory here. Next slide, please. So today's webinar on traumatic brain injury, intimate partner violence, and family court is part of a project titled Supporting the Health of Survivors of Family Violence in Family Law Proceedings, which is funded by the Public Health Agency of Canada. And this project is a collaborative effort amongst the Alliance of Canadian Research Centres on Gender-Based Violence that runs from 2020 to 2023 with Western University as the project lead. And the purpose of this project is to initiate, host, and support a community of practice group that brings together experts and practitioners in the family violence and family law sectors to enhance support for survivors in the family law system. And this is mainly done by offering opportunities for collaboration, education, and training for family violence and family law professionals through webinars such as the one we are hosting today. Next slide, please. I want to make a few acknowledgements first to our guest speakers today who have put together a wonderful and informative presentation, Dr. Michael Ellis and Ashley Stewart. I would also like to acknowledge the Public Health Agency of Canada, our project funder, the Prairie Action Foundation, who is the funder of the Resolve Network, Dr. Kendra Nixon, the director of Resolve, Patricia Carasoni, Resolve Digital Communication Specialist, and lastly, a big thank you to the U of M audiovisual team who is helping us host this webinar today. And next slide, please. So just a few Zoom guidelines before we get started. First, the webinar will be recorded. All participants will remain muted during the webinar and have their videos turned off. And participants can ask questions to our speakers by using the Q&A button at the bottom of the screen. And we will have about 15 minutes for a Q&A discussion at the end of the presentation where our speakers can answer any questions that you may have. So next slide, please. All right, so our schedule. So first of all, we're going to start with our welcome, land acknowledgement, and introductions, of course. Our guest speakers will then cover a few topics, including an overview of intimate partner violence and intimate partner violence-related traumatic brain injury, the role of frontline service providers in recognizing and responding to those with suspected IPV-related head trauma, and how intimate partner violence-related traumatic brain injury can present challenges for survivors in the family court system. And as I mentioned before, we will have time for a Q&A at the end and then have our closing remarks. Next slide, please. Poll, perfect. So we have a poll for everyone here just to determine which sectors our webinar participants are from today. So it would be great if everyone could take a second and make their selection before we get started here. Great, I think that should be enough time for everyone to select their options. Perfect, okay. Oh, well, welcome everyone. We see quite a few people from a variety of fields, so that is great. Welcome to everyone here today. Wonderful. Okay, next slide, please. All right, I want to give a warm welcome to our speakers today. We have Dr. Michael Ellis, who is an assistant professor in the Department of Surgery, Section of Neurosurgery at the University of Manitoba. He is the medical director of the Pan Am Concussion Program, a clinical program that provides multidisciplinary care of patients with concussions and other forms of traumatic brain injury throughout Manitoba and Central Nunavut. His clinical and research interests involve the use of telemedicine to deliver care to underserved remote and rural communities and the development of clinical programs and systems of care that serve patients with intimate partner violence, traumatic brain injuries. And we also have Ashley Stewart, who is a registered psychiatric nurse and has been practicing forensic nursing for 15 years. She is the current coordinator of the Forensic Nurse Examiner program at Health Sciences, which sees all ages of intimate partner violence and sexual assault. Ashley teaches at Duquesne University in the Master of Forensic Nursing program and is active on the board of directors for the International Association of Forensic Nurses. So without further ado, I will pass it on to our speakers today.
Can everyone hear me okay and see the slides? Ashley, can you confirm that you can hear me and see the slides?
Yeah, we can hear you and we can see the mic, thanks.
Okay, perfect. Okay, so thank you so much for the opportunity to present to all of you today. We want to kind of give you a bit of an overview on traumatic brain injury and intimate partner violence. Many of you are quite experienced in intimate partner violence and may have had some interaction with clients and survivors who have sustained traumatic brain injuries. And then want to give you some information just on challenges for survivors involved in the family court system. But we also want this to be an interactive webinar, because we find that when we do give these presentations to a variety of different stakeholders, we learn a lot from the stakeholders' experience. And again, as is often the case, a lot of the sectors that support patients who are exposed to intimate partner violence are oftentimes siloed. So it's nice to be able to kind of understand the lived experiences of survivors and those that provide care and support to this patient population. I'm just having trouble advancing these. Oh, there you go. So the objectives here are just to provide a brief overview of intimate partner violence and intimate partner violence traumatic brain injury, discuss the role of frontline service providers play in recognizing or responding to those with suspected IPV-related head trauma, and then we're going to discuss how IPV-related brain injury can present challenges for survivors involved with the family court system. So as many of you know, intimate partner violence refers to behavior by an intimate partner or ex-partner that causes physical, sexual, or psychological harm, including physical aggression, sexual coercion, psychological abuse, and controlling behaviors. And it's estimated by the World Health Organization that 1 in 3 women globally have experienced physical and or sexual IPV or non-partnered sexual violence during their lifetime. Many of you are aware of some of the risk factors for intimate partner violence, which include female sex, younger age, lower socioeconomic status, lower education status, and previous exposure to child abuse or IPV. But we also understand, especially in Canada, that marginalized populations such as those who are Indigenous, have physical or cognitive disabilities, identified as two-spirited LGBTQIA+, or vulnerably housed or work in the sex trade industry can also experience IPV and face unique barriers to accessing care. As many of you know, Manitoba has the second highest rate of police-reported intimate partner violence per capita among the Canadian provinces. I believe still Saskatchewan is the highest among the provinces. Intimate partner violence can have significant short and long-term consequences on survivors and their families. One of the things that I didn't realize early on in my career as a neurosurgeon was how common intimate partner violence was and how common survivors of intimate partner violence sustain injuries to the head, face, and neck. Indeed, these are the most common physical injuries sustained by individuals who are exposed to IPV. Traumatic brain injury is generally defined as the transmission of biomechanical forces to the brain that leads to abnormalities in brain structure or function. And this can exist along a clinical pathological continuum from concussion at one end all the way to more severe structural brain injuries such as intracranial hemorrhages, contusions, and other types of injuries. Research studies using a variety of different samples suggest that among IPV survivors, 92% sustained blows to the head and face, up to 75% sustained traumatic brain injuries. And given the nature of IPV, a significant proportion of those with IPV-related brain injuries often experience multiple brain injuries, with some patients reporting having sustained injuries that were too many to quantify. In addition to injuries that result from blunt or penetrating head trauma, IPV can result in brain injuries that are secondary to non-fatal strangulation. Attempted strangulation has been reported in up to 68% of women in abusive relationships, and it is an important risk factor for intimate partner homicide. Those presenting with IPV-related head trauma can also sustain injuries to the eyes, the face, and the neck. Facial trauma can result in a variety of different symptoms and different types of injuries, including contusions, lacerations, facial fractures, dental injuries. And these can present as localized pain, bruising, swelling or deformity, or in some cases, deficits in sensory and motor functioning. Trauma to the orbit can lead to a spectrum of injuries as well that can range from periorbital contusions to subconjunctival hemorrhage, corneal abrasions, retinal detachment, orbital fractures, injuries to the muscles that control the eye and the nerves that control the eye. And this can result in localized pain and swelling, blurred vision, double vision, complete visual loss, or visual field defects. Strangulation is important and is often overlooked in patients who are exposed to IPV, and strangulation can result in injuries to a number of different structures within the neck, including the cervical spine, airway, esophagus, blood vessels. It can lead to injuries to the brain, which is caused by the disruption of oxygen or blood flow delivery to the brain. And there can also be other injury to other soft tissue structures, such as lymph nodes. And clinically, these types of injuries often present with hoarseness or voice changes, difficulty swallowing or talking, or stroke-like symptoms. This is kind of a generic list of the most common presenting symptoms in patients with concussions. We oftentimes will divide these into physical, cognitive, sleep, or emotional symptoms. Some of these symptoms are quite obvious, such as headache, dizziness, sensitivity to light and sound, changes in vision. But some of these can be more subtle and can be more difficult to recognize among patients and survivors, as well as frontline service providers. This can be things like not feeling like yourself, difficulty in remembering, sleep disturbance, or having change in the patient's or client's emotional status, such as being more irritable or feeling more emotional or more sad or anxious than normal. These are a list of sort of red flag symptoms that may signify that more than a concussion has occurred or the presence of another injury. And these include seizures, neck pain, repeated vomiting, confusion or a change in level of consciousness or mental status, weakness or numbness involving the extremities of the face, double vision, blurred vision, or loss of vision in one eye, significant facial bruising or swelling, slurred speech, or as I mentioned before, difficulty swallowing or breathing. In addition to acute physical injuries, survivors of IPV are also at an elevated risk of developing a number of mental health outcomes, including depression, anxiety, post-traumatic stress disorder, and substance use disorders. So it's important, as many of you know, when working with survivors of intimate partner violence, and especially those that sustain injuries related to head trauma, it's important to recognize that there are often several intersecting factors that can impact survivor symptoms and functioning. So we can have symptoms of a traumatic brain injury, symptoms that are a result of exposure to intimate partner violence and the trauma associated with that, mental health conditions and substance abuse conditions, as well as injuries to the eyes, face, and neck. So oftentimes, some of these patients from a medical perspective are quite complex, and that we have a number of different things that are going on that maybe impact symptom reporting. As many of you know, individuals exposed to escalating and more severe forms of IPV can be at risk of intimate partner homicide. We also know that children, IPV has an important impact on families. Children who are exposed to IPV are at an elevated risk of several adverse health outcomes, such as the development of mood disorders, anxiety disorders, post-traumatic stress disorders, substance abuse, school-related problems, and different forms of abuse in the future. It's important to understand that although we don't expect every frontline service provider to be able to diagnose intimate partner related brain injuries, it's important to understand that everybody who interfaces or encounters this patient population or client survivor population does play a role in recognizing and responding to clients with suspected IPV. And in order to do this, frontline service providers need to be able to become educated on the signs and symptoms of IPV, traumatic brain injury, understand the intersecting factors that lead to IPV and impact the lives of survivors, and develop procedures and resources that direct clients to appropriate medical and supportive services. We're very fortunate to have a number of key resources that have been developed. So if you'd like to view more information about how family violence shelter workers can learn more about the intersection between IPV, mental health, substance use, and traumatic brain injury, the Resolve program partnered with the Manitoba Association of Women's Shelters to develop a really cool web-based training module that's free and available online at the link below. We also work closely with the Concussion Awareness Training Tool and the SOAR project, which also developed a women's support worker module that sort of provides some background information on IPV-related brain injury, how to recognize, screen, manage, and sort of care for clients with these types of injuries. For more information on intimate partner violence, traumatic brain injury, you can also visit the ABI Toolkit, which is a great website that provides more information on IPV-related brain injury, the SOAR project, which has a number of training tools and resources, and POCTUTIT, which we're very fortunate to work with, who's developed some IPV-related brain injury tools that have been customized for Inuit women and populations. So I'm going to hand this over next to Ashley, and then we'll pop back for questions at the end.
Perfect. Thanks, Dr. Ellis. So I'm going to go a little bit more into kind of the medical side of things and what that assessment role might look like by a healthcare provider, what we might be looking for during an assessment, and how it might impact the different sectors that you all are working in. I think one thing that Dr. Ellis and I have really come to recognize over the past couple of years we've been doing this work is that obviously not everyone's going to come to the hospital. And I think sometimes in the different services that we work in, we expect individuals and survivors of violence to go get medical attention right away, and to give a history of all their injuries all the time, and always expect that we have that information. But we've learned that's not always the case for a number of different reasons. So although intimate partner violence is very common, there's many survivors that don't come see us, whether that be in hospital or in community-based clinic. Sometimes they're not able to, sometimes they don't feel like their injuries are severe enough. There's a lot of reasons that they may not seek medical attention. Some individuals we've learned as well, and I see this quite a bit in my practice, is they might seek medical attention, but maybe only if it's severe enough. So maybe, if they're hit in the head and they've regain consciousness, or they don't have a lot of symptoms, they won't seek medical attention. Or sometimes folks might come and see a healthcare provider and not tell us what has happened, but say, oh, I fell and hit my head, or I fell down the stairs, or someone, knocked me on the head, but often may not disclose that someone intentionally hurt them, such as their partner, for a number of different reasons. Sometimes that's guilt, it's shame, it's fear of future abuse. So for a lot of individuals, they just don't have the access to go in and seek that medical care because their partner prevents them from accessing that. Sometimes they don't have transportation, someone to care for their children. We've also had circumstances where someone has come to get medical attention and their partner has followed them there. And so that becomes a huge safety concern, as well as waiting for them when they leave hospital or clinic setting, and then they're at risk for even some more severe violence. So there's many reasons, I think, for us to understand as helpers and as providers that many patients won't seek medical care for some of these reasons. Sometimes there's a lot of fear. Sorry, Mike, I just want to go back to that for a minute. Even of what may happen to their children, right? Or Child and Family Services or Child Protection Services going to be involved as well. Some people are just uncomfortable disclosing what has happened to them, and whether that's for confidentiality reasons, or they just feel too embarrassed to tell that provider, or they're worried about someone finding out. There's many reasons they may not disclose and tell us they're there, and that injury happened for another reason. Okay, you can go to the next slide now. The other thing to consider is that some survivors also may not report the violence to police. And sometimes I find, my role largely kind of crosses over from medical healthcare side and sometimes into the law enforcement and justice side, whether I'm testifying as a fact or an expert witness. And sometimes we rely on some of that, those police reported data or some of the medical reports to be evidence that, this physical assault or sexual assault took place. We know that many individuals or survivors may not report to IPV or domestic violence to the police as well. Sometimes survivors also do not wish to have their partner charged. And that's, again, for a number of different reasons that we hear from people that we see. Sometimes it's that they feel that the violence is going to improve. They still love their partner. There's different reasons as well: housing, finances, documentation, immigration status, being a family unit, being fearful of their children being apprehended. Some survivors also have had negative experiences, whether that be interacting with law enforcement in the jurisdiction they live in, or sometimes even the justice system if they've had previous exposure to violence as well. So sometimes that impacts them wanting to come forward and make a formal statement. And some survivors want to seek legal guidance, but they don't know how to access that legal guidance and advice. Some individuals don't know what their options are. I have found, especially if I'm working with someone who may be a newcomer to Canada, they're not aware of kind of what their rights are and what their resources are and what they can do confidentially without their partner or family finding out as well. So I'll talk a little bit about what that assessment might look like, whether that's a forensic nurse or another healthcare provider. So when we see people in a clinical setting, we range from patients who may present with a history of blunt trauma to the head or face, a blunt trauma that could be with someone's, hands, legs, a blunt object, or sometimes a disclosure of strangulation as well, or sometimes an individual might disclose that as choking. Sometimes we have patients who come in with a very vague history and might say, oh, you know what, I got physically assaulted, but they might have some very limited recollection of what happened to them. So we may not get a lot of detail at that first interaction with that healthcare provider. And that's where sometimes in Dr. Ellis's setting, when he's seeing people in follow-up, he gets a little bit more history. Sometimes when I see people in a real acute setting, they're exhausted. Sometimes that violence has gone on for 8 to 12 hours or even more. Sometimes there's a lot of swelling, pain, sometimes a loss of consciousness, that it's difficult for people to recall all the details of what happened to them. And so sometimes that information we might not get on that initial encounter, but we get more information on follow-up about those injuries as well. What we do try to do is to have a high index of suspicion that domestic violence or a head injury has happened. When we see patients who really have no recollection of what happened, sometimes they do or don't report a loss of consciousness, but they have injuries to the head, the face, or the neck. So when that's happened and someone has limited recollection, then we're really concerned something has happened there, right? And depending on the type of injuries we're seeing, sometimes we can correlate that with something that might have happened, right? So for example, an injury that's intentional by someone might look very different than someone who says, oh, I fell against an object or I fell down the stairs. The mechanism of how those injuries occur and how they present are going to be different. Patients can also present with a wide range of symptoms. So sometimes we have people who come in that might have some of those contusions or bruising that Dr. Ellis talked about, some swelling or minor injuries to their face, maybe a headache. And we can see the extent to the opposite spectrum where people might have a subdural hematoma or hemorrhage, have a bleed inside their brain, have an anoxic brain injury where they have had a loss of oxygen, and sometimes admitted to the intensive care unit. So we see a really wide range of people who come in. One thing I think Dr. Ellis and I have talked about over the last couple of years, and I think kind of amazes us, is that we see so much protocol and information going into concussion protocols for sports-related injuries, and we take those people out of the line of play and make sure they have really good follow-up, and we really watch their symptoms. And the more him and I have started to see survivors of domestic violence who have, traumatic brain injuries, concussions, and strangulations, we recognize where we really need to get better in this field, because often those individuals are at a significantly higher risk for repeat head injuries because they're going right back into that line of play, and they don't have a helmet on, and their injuries, are just as severe, if not more, right? So the other thing that we will do in a healthcare setting is assessing for a brain injury after intimate partner violence. So some of the things we want to ask, depending on what their disclosure was when they came in or what their injuries are, is were you hit in the head with anything, with either fists, kicked, an object? Were you strangled or choked at any point in time? You know, when did that occur? How many times did it occur over this time period? What were you hit with if they were hit with something? That gives us some information about what might be happening medically as well, and what imaging or diagnostics that might need to be done in that healthcare setting. Do they fall and hit their head? If someone was choked or strangled, were they lifted off the ground? Was their head banged against an object? The other thing we'll ask is if they lost consciousness, or if they're experiencing any visual changes at all, or having any seizures. And the one thing that's really important to understand, and I think that Dr. Alice and I have learned over time, is that sometimes an individual has no idea if they've lost consciousness, because you can get a period of amnesia or loss of memory with that loss of consciousness. So often, again, we will have a high index of suspicion if an individual has a kind of a lapse in time where they don't recall what happened at all. Then I'm really concerned, you know, did that individual maybe lose consciousness? The other thing we're really concerned about, and this is particularly with strangulation and choking, is if that person lost bladder or bowel control. And we know we have really high rates of strangulation with intimate partner violence. And as Dr. Ellis mentioned, it is a huge predictor for future homicide by their partner. If someone is at the point where their partner is strangling them, they are at 7.5 times more likely to be killed by their partner. And that's quite firmly, you know, we see that in the research now. So when someone has lost bladder control or bowel control during that strangulation or just after, we're really concerned about some of the impacts medically to their brain and to their body after that has happened. We also want to know what other symptoms that they're currently experiencing. So are they having headaches? Are they seeing things in their field of vision? Are they having any weakness anywhere in their face, their body? Are they having a hoarse voice? Are they having any bleeding or peaky eye or hemorrhages in the inside of their eyes or on their face, and looking for any of those physical injuries as well. So that healthcare provider will document those. We'll document those injuries and some of those subjective symptoms as well in that medical chart. The other thing we want to ask our patients about is, do they have any past history of being hit in the head, choked, or that traumatic brain injury? Because we want to know if this has happened before as well, and what injuries or what changes they might have seen since then, because maybe they haven't had any medical care. So if they have been hit in the head before or been strangled, we want to ask them, you know, are you having any difficulties with headaches, fatigue? What's your attention span like? Are you having any difficulties with concentration right now? What about your sleeping? Are you having any changes in your mental health, like your mood, anxiety, depression? Is there any difficulty in your day-to-day functioning? You know, something I think we've learned as well over the couple of years of seeing patients and asking these questions is individuals sometimes will tell us, yeah, you know, I've had a really difficult time learning new tasks or retaining new information. My memory is so different, or I have a really difficult time keeping up at work now, or I've noticed a significant change in my anxiety. Are they having problems with memory or dizziness or poor balance or any visual disturbances? So this helps us give us more information on any past injuries, and then it helps from referring someone to a physician and a specialist like Dr. Ellis, so that he can hopefully provide maybe some intervention to help them recover from some of those impacts from previous head injuries as well. And then of course we'll ask if they had any medical attention for those prior traumatic brain injuries or concussions, and if not, we can make sure they receive that care. So some of the acute impacts of a traumatic brain injury can be that loss of consciousness, memory problems, having problems with one's vision. So that can be seeing spots, having maybe tunneling vision, seeing different lights. Something else we might see could be tinnitus or ringing or whooshing in their ears. Folks may be confused or disoriented. And after something like a strangulation, we actually can see really agitated behavior and sometimes combativeness. And sometimes that can be mistaken for someone who's just being very difficult to deal with, but it's because of the lack of oxygen to that person's brain from the strangulation. Folks can become lightheaded, dizziness, have problems with a cough for a little while, and have headaches and emotional changes as well. So before I go into the impacts of family court, the other thing I kind of wanted to touch on is a strangulation case study and a bit of a trigger warning. And we probably should have done this a little bit earlier as well, because this information can be really hard to hear. But I was at a conference last fall, and there was a presentation on a strangulation case study, and the survivor who was part of that incident really wanted this information to be shared to help providers kind of worldwide. And one thing that was really, I think alarming to me with this individual is there was surveillance in their apartment. And so it shows a whole day history of that person being assaulted. And at one point she's strangled by her partner and is unconscious for 6 minutes. And then she's back sitting on the couch and she's drooling and having some facial droop, and she keeps kind of falling asleep, and her partner is becoming kind of concerned. He keeps trying to, wake her up, put cold water on her, and is becoming really concerned. We fast forward hours later in that incident, and law enforcement show up, and her family. She looks completely different. She's walking, talking. No one would have had any idea at all what she physically looked like 4 hours previous. And she also had no idea that she had lost consciousness. So that was a really good learning tool, although unfortunate we had to learn from that for myself and law enforcement and other people I work with, because not everyone is going to remember that they lost consciousness because of that amnesia, right? Or we're not going to see those symptoms that we saw on that surveillance video, because by the time that person presented to hospital, they weren't showing a lot of those immediate symptoms. They weren't drooling, they weren't showing that different change in consciousness where they were appearing really sleepy. So it was really important for us to really remember how those stages can really change quite rapidly when someone has been hit in the head or has been strangled, and how quickly those symptoms might recover, and we might not see them on presentation. And so we have learned as providers as well to make sure we're paying really close attention to strangulation and brain injuries, because we have had case reports in North America where people have died after those things and had little to no injury once they present to hospital. And so that's why it's so important for us to provide a really good assessment to those individuals when they are presenting right after that acute phase. So how you may see this impacted in family court, and I think Dr. Ellis and I are really interested to hear what other people's experiences are as well, and what you might be seeing in your different settings and what challenges may present themselves. But how this might present themselves is you may have an individual who has memory impairment. They may not recall all of the details of their assault. And part of that can be because of some of the impacts of that traumatic brain injury. And it also can be because of the neurobiology of trauma as well. So we know through research, when someone goes through and experiences a trauma, such as a physical trauma, like intimate partner violence or sexual assault, how our brain takes in that information and that fight or flight or freeze response is very different. Our brain is not able to take in that information and always store it in a place where we know how to recall it. And instead, our brain stores it in a million different areas. So you can kind of picture an office with Post-it notes all over. So then when we go see a healthcare provider, or we talk to law enforcement, or we're on the stand in court and we're asked to recall all of those details, very time sequenced and question on those, it's very difficult for individuals to be able to put all of that information together because of the impacts of that trauma physically, but also psychologically. You also might notice in the court system that you might have a lack of documentation or medical records. You might have an individual that can say, these are all the times that I was hit, but there may not be medical attention because those individuals didn't seek medical care for all of those reasons that we listed previous. Same with the lack of police reports or police involvement. Not everyone is going to report to law enforcement each time as well. And we know that often individuals may not seek law enforcement until a number of times after that violence happens, right? And then the impacts to the survivor's statement of what has happened as well. So again, I think keeping all this information in our minds, if you're someone that's dealing with a survivor and you're hearing that statement, knowing all the factors that impact that, if they've had law enforcement involved before and made a formal report, if they've got medical attention, and maybe they've got medical attention, but they didn't specifically go to that provider and say, my partner hurt me in this way, for many of those different reasons. So those are some of the ways that I think we see it impacting in court. So some of the things that Dr. Ellis and I have learned in just a couple of years that we started doing this work and seeing individuals is that people may also not be able to attend follow-up or seek medical attention at all. And sometimes that's because of how visible their injuries are. And I think that's something that we ignorantly didn't think of before, but we might book a follow-up appointment and individuals were not comfortable attending a clinic setting somewhere for a follow-up appointment because they still had a lot of injuries to their face and they didn't want to go out like that. So sometimes we could work around that and say, would it be better to come a couple days later? Or, you can come at this time, there's maybe less people in the waiting room, or we can meet you kind of downstairs and bring you up, and just really trying to provide that privacy a little bit more. Sometimes it can also be impacted by people not having the availability to get to their appointment. So it's really important that we assess that need as well. Do you have transportation there? Do you have someone who can care for your children? Do you need a note to be off of work? Are there safety concerns? If you're still living with your partner, are you able to safely attend an appointment? Sometimes patients as well, and I described this before, just may not be able to give a clear history, whether they're seen in an emergency department or in a community setting. If you're seeing them right after an injury has happened, and that could be because of the injury themselves, sometimes they can give a little bit more history at that follow-up appointment because some of those, that swelling, that pain has started to decrease a little bit. Sometimes patients may disclose a history of being hit in the head or strangled, but they might not disclose who did it. So we often will tell healthcare providers we're working with, if someone comes and says, oh, I was hit in the head, ask one more question: who hit you in the head? Because that might help us then trigger some of the other responses in our community to make sure that person gets the right services, or making sure we can really maintain their confidentiality and maintain their privacy in your clinic, your hospital setting. So some of the settings I've worked in, we've tried to make sure that their name is kind of blacked out in our medical system, so someone can't just call and ask about them, because that can be a concern as well, as maybe that partner or family member is waiting outside for them, and we've had that happen. We often find as well that patients have had a very long history of violence. So often when you might be seeing them, this is not the first time. And sometimes or often law enforcement have not been involved and they have not sought medical attention for those multiple reasons. And sometimes not until it's so severe that they need to be taken by ambulance to a tertiary healthcare setting. And then lastly, often patients report histories of increasing headaches, poor concentration, visual difficulties, and increases in mental health symptoms because of some of those repeated injuries to the head. So it's important we kind of ask and be aware about those as well. So I think that's all we have for now. We're excited to open it up to questions. Both Dr. Ellis and I have our contact information there, so you can feel free to reach out if you have other questions or feedback for us, and we'll open it up to see what comments and questions there are.
Thank you, Ashley and Michael. I'm going to go through the Q&A, and I know I've been busy following the chat and the Q&A, and I think there's some really great questions. I think this is maybe for you, I guess for either of you, but I think it was mentioned in your presentation, Ashley. One registrant has asked, how do you know or how do you differentiate between loss of consciousness as a result of strangulation or head injury versus a trauma response whereby the patient dissociates or memory loss as a mechanism of dealing with the violence?
So that's a great question. And I don't know that there is a way to really differentiate between that unless you're there and you can witness that. And I'll let Dr. Ellis chime in case he has more knowledge on that. But that's, I think in my experience, that's impossible to do. Sometimes we can correlate if there's any other symptoms with that. So if someone didn't have an injury to the head and it was more of a trauma response, and they might not have some of those other symptoms or some of those objective signs. But otherwise, unless you're there and you've kind of witnessed, was it an actual loss of consciousness, or was it more of a psychological response, or what we sometimes call tonic immobility, which is a trauma response, which people freeze. It's really difficult to be able to differentiate those. Dr. Ellis?
No, I think I agree with Ashley. I think a lot of times when patients are exposed to intimate partner violence and sustained head trauma, there's oftentimes multiple mechanisms of injury that they can sustain during a course of an assault. So they may have been strangled multiple times. They may have been struck in the head multiple times. And there may be a period where somebody lost consciousness or it can't remember certain details and has a bit of difficulty kind of putting things together in a chronological order. So I think from a clinical perspective, it's definitely difficult to obtain a clear history sometimes in patients about whether or not they have lost consciousness, for how long, how that's impacted memory. And then there are also instances where patients can have some substances on board that may also impact their ability to recall whether or not they lost consciousness, or whether or not they feel there's a period of time that they don't remember the events that took place.
Okay, thanks, Ashley. Thanks, Michael. Another question is about, I guess, judicial awareness or education. Citing a media article where a judge really dismissed choking or strangulation because there wasn't, very visible injuries. Are you aware of any kind of judicial education or awareness about traumatic brain injury and intimate partner violence? Like, do you have a sense of that?
So I don't think there's any mandatory education. I think we're starting to see mandatory education for some areas. I think sexual violence, but on intimate partner violence as well. So I think there's a lot of advocacy there ongoing. And in particular with strangulation and traumatic brain injuries, I think there's a lot of work that we have to do in educating a lot of the individuals and services we work with, even us as healthcare providers, and many that we still work with, still just kind of aren't aware that if someone has been strangled or hit in the head, that not everyone is going to have a lot of physical signs. And in fact, often they won't. And, even I think Dr. Ellis, saw someone not that long ago who had a really significant strangulation and maybe had a lot of bruising, but then on actual imaging and diagnostics, there was nothing pathophysiologically on those. And sometimes we see providers even relying on something in the diagnostics even to diagnose a concussion or a mild traumatic brain injury. So I'm not aware of anything that there is mandatory for justice officials or judges at the moment, but I think that advocacy is ongoing, and I would encourage everyone who's a participant here, including us, to continue to have those conversations in the areas that we're working in. And if there's different research that you would like in those areas, please reach out and we can definitely provide you with that.
Well, and I guess a follow-up to that, Ashley, what would you suggest for survivors who you're working with who have had this response from service providers or judges that they downplay some of these injuries? And I've had others in the chat that have said that it has been their experience where they haven't been able to recall, as you said, the sequence of events, and that's been used to undermine their credibility. So what can survivors do so that this doesn't happen?
So I think I would advocate them to reach out to maybe the attorney that they're working with, so whether this is criminal or family court, and to let them know that, I know this, personally, because they've just been a survivor of this, but that they know this is backed up in medical science and research, that often people don't have injuries, and see if you can advocate for that attorney to reach out to someone who's a medical professional or an expert witness, or to even just seek out that research to to back up and help prove what their experience is, which is really unfortunate that they have to even do that, but that's what I would suggest.
Thanks, Ashley. And I guess a similar question as you were speaking, it came to mind about how you were referring to kind of this trouble recalling events or trying to kind of recall the sequence of events. And I guess, how can family lawyers prepare their clients so they can retrieve those memories? Like, is there anything about asking questions or how we can prepare someone that we know that they've had a traumatic or acute brain injury, they've had to have had significant trauma, and both of those things may impact, like you said, the processing of events. Is there anything that, say, family lawyers can do to help their clients prepare for that so they can answer those questions, so they won't be considered as unreliable or not credible?
So I'm not an expert in forensic interviewing, but I would reach out to someone. We do have forensic interviewers in Manitoba and Canada. Another really great researcher and expert on this who does a lot of training with law enforcement as well as lawyers and judges is Dr. Rebecca Campbell. And she's done a significant amount of work on this. She's at the University of Michigan, so I'm happy to provide her contact as well. But yeah, there are ways to help that maybe individual recall. I don't know if Dr. Ellis has more feedback on that as a neurosurgeon, but that's kind of what I would say.
No, I think it's a good question, but definitely outside my scope of practice, to be honest. I think one of the general things that is going to come about with probably a lot of these questions is just there's a massive gap in just overall awareness for frontline service providers. So, and I would include myself as one of those. So I'm a neurosurgeon who up to about 3 years ago was a medical director of a concussion program that was generally focused largely on sport-related injuries. So until about 3 years ago when I met Ashley and started to explore opportunities to provide care to this patient population, really did not understand the burden of traumatic brain injury among survivors that have been exposed to intimate partner violence and how those patients present. And I think if you look in the literature on this subject, there is some really good systematic reviews looking at prevalence of TBI among IPV providers, but there isn't, or among IPV survivors, but there really isn't a lot of information about what this type of injury looks like clinically and how patients sort of present and report the injuries that they have. And so I think there's a lot to learn, but at the same time, I think there's opportunities like this where we can kind of share our experiences of what our experiences with patients and clients and survivors, and just provide that basic information about understanding the intersection between IPV, TBI, other factors such as mental health and substance abuse concern, and then just trying to educate people on, being aware of those signs and symptoms. Like I said, we don't expect frontline service providers to diagnose these types of injuries, but I think everybody, similar to sport-related concussion, can be trained to kind of recognize these injuries, or at least have a flag go up to say, I suspect you may have had a brain injury, and refer people to appropriate care and provide them supportive resources. But I think a lot of these questions regarding amnesia, loss of consciousness, those types of things, I don't know if there's enough literature that's been studied in this patient population to answer a lot of these types of questions.
Great, thanks, Michael. Another person has asked, can a person begin to have seizures after years of experiencing intimate partner violence? If so, how can you diagnose it from other issues?
And again, I'm speaking from a little bit of lack of experience, but most patients who sustain head trauma and have seizures very soon after the head injury. So some patients can have seizures that occur immediately after head trauma, and some may occur within, the first few days or weeks following head trauma. It's less likely for patients who have never had a seizure following a traumatic brain injury to develop seizures over time. And some patients who do sustain head trauma and have early seizures can be at risk of developing epilepsy, which is kind of long-term ongoing seizures. But seizures do have a number of different causes. And so it's important that patients who do have seizures be seen by a neurologist and a physician to try to identify what the causes of those seizures may be.
Thanks, Michael. And again, this next question might be, again, more about education and awareness, but what can, frontline service providers do, or where can they direct someone if they believe that there is a traumatic brain injury being experienced or has occurred? One has noted in the Q&A that when the client did reach out to their physician and explain some of these symptoms, they kind of dismissed it or chalked it up to anxiety, depression, and not an actual traumatic brain injury. So where should service providers be referring or telling their clients to go somewhere specifically? Again, that's going to depend on where that person is located, right? If they're especially in a rural or remote area or northern area. But I don't know if you want to comment on that.
I can speak a little bit to that, and Ashley, I'm sure I'll have more to add. in general, all patients who sustain a suspected traumatic brain injury should have a medical assessment when it's safe to do so. But we do know that there are significant gaps among physicians in terms of screening for IPV, understanding, just basic understanding regarding concussions and traumatic brain injuries. And then we do know that across Canada, there are limited programs that provide specialized care to patients who have traumatic brain injuries as a result of intimate partner violence. So this is one of the issues that we have a lot around things like screening. Does it make sense to screen for an injury if there aren't sufficient resources to be able to care for that patient? And that's something that comes up in a lot of discussions that we have on this topic. It's important to understand that when patients do sustain head trauma as a result of intimate partner violence, there can be a lot of different injuries that, if they don't seek care for, can have significant impacts. So these sometimes can be more life-threatening injuries, such as intracranial hemorrhages, dissections, stroke, things like this. Some patients can have facial trauma where they could have permanent loss of vision, facial fractures that won't be healing appropriately if they don't have access to care. So I do think in general, the basic message that we've been trying to convey to frontline service providers across different sectors and across different regions of Canada is that patients or their survivors of intimate partner violence who have sustained head trauma should be referred to the nearest medical facility to have a medical assessment. But there's a lot of work that we need to do in terms of educating people across all different types of healthcare disciplines about IPV and traumatic brain injury and how to provide more collaborative multidisciplinary care for this patient population. And I'm sure Ashley is going to talk to you about the role of forensic nurses in this setting.
Yeah, I think I would agree with everything Dr. Ellis has to say. If there is a forensic nurse in the area that you live in, referring that person to go have a forensic nursing assessment who can do some of that documentation and that medical assessment. And then hopefully maybe they know of some other providers in the community that they can refer for medical attention as well, or even presenting to their local urgent care or emergency department.
Great, thanks to you both for that. Another great question. Just wondering about the connection between suicidality among survivors with acute or traumatic brain injury, and if that is kind of addressed in the assessment of brain injury.
So I think it's well known that those survivors of intimate partner violence may be an elevated risk of certain types of mental health outcomes, such as depressive disorders, anxiety disorders, post-traumatic stress disorder, and suicidal type behavior. This is something that we assess for in all of our patients. So we always want to ask patients about their mental health, whether or not they're feeling more sad or anxious than normal, features of post-traumatic stress disorder. And then we screen patients for whether or not they've had any recent thoughts of self-harm or any type of self-harm behavior and intent to commit suicide. This oftentimes, again, what we're trying to do is, screen for those acute issues to make it from a safety perspective. And then try to connect those patients to mental health resources when available in their jurisdiction.
And I would echo that for forensic nursing assessment. That's something that we will assess for in every single patient, regardless of history or how they present, but we will also do a suicide risk assessment as well.
Okay, I'm just going now to the chat. I see some have asked question in the chat. Okay. You might have addressed this, but maybe just quickly reiterate if you can. Can you please speak to the impact of strangulation, immediate, short-term, and long-term?
So I'll let Dr. Ellis touch on this as well. I don't think we have a ton of research on the long-term impacts of strangulation. I talked about some of the short-term ones we have, which might be some of those symptoms that people are experiencing, like having a hoarse voice, a sore throat, maybe some difficulty with their vision. Of course, in severe cases, we can have stroke-like symptoms. But yeah, so other than those kind of short-term impacts, we do see people who have repetitive strangulation as well, but we don't have a ton of research that shows if there's a cumulative effect to those. But I'll let Dr. Ellis chime in if he knows more about that.
No, I agree with Ashley's points. I think, at least in our own clinical experience, we're oftentimes dealing with the acute impacts of strangulation, whether it's, acute injuries. Obviously, if there's patients who have sustained dissection to some of the arteries in the neck, there can be a long-term risk of stroke if that isn't addressed properly. But I think in terms of the long-term effects of either one instance of strangulation or repeated strangulation, I think we just don't have the research to kind of support a lot of discussion on that. And it's also difficult. It may be difficult to study that in the future as well, because you would be looking at patients who have had isolated episodes of strangulation, whereas we know that a certain proportion of IPV survivors will sustain injuries related to strangulation and coexisting head trauma in different types of settings. So that's a hard question. That'll be a difficult question to answer in the future from a research perspective.
Great, thanks, Michael. Michael, another question directed for you. What literature and scientific studies are lacking? If a researcher were to take on these studies, what should the focus be on to contribute to the medical community?
I think those are great questions. I can say that as a physician, when I started seeing these patients, there wasn't a lot of literature to sort of look to guide the development of clinical programs such as the one that we're developing here at Pan Am Clinic. When I started seeing patients, I essentially reached out to people in the field who I knew were doing some research in this field, other experts and things like that. One of the biggest gaps in care during that period of time is that although we have really good clinical practice guidelines for concussion and traumatic brain injury, there's very little of those guidelines that really points to how to care for patients who have suffered these injuries in the setting of intimate partner violence. So one of the things that we did was bring together a group of people through the ABI toolkit and SOAR and the CAT online tool to develop a bit of a medical provider resource, which was a bit of a just an initial resource that physicians could read and give them a little bit of a structured approach to caring for these patients. There are some really good research groups, but I think the questions really come down to, what are the needs of the individuals who are caring for this patient population? Obviously, there's a lot of clinical research that needs to get done, but I think a lot of the research can focus a lot on clinical or specific research questions that are important for those that care for these individuals. So one of the things that we've done is we've worked with a group called Enigma, which is a IPV, which is a global research group that's brought together frontline service providers across the world to discuss these issues. And we've created something called a global knowledge exchange network, where we're bringing together frontline service providers to have some informal talks about IPV and brain injury in that intersection, and then using that conversation to develop some specific research questions that are specific to the issues that frontline service providers are raising. So my advice is really to try to talk to those people that are really interacting with these patients across different sectors, trying to find some of the challenges that those providers are encountering, and then trying to develop those collaborations to try to answer some of those questions.
Great, thank you. Another participant says, thank you for your excellent presentation and good work on an issue that is so prevalent and highly detrimental to health and well-being. As you've noted, there is certainly a gap in awareness and training for health and social service providers in intimate partner violence and traumatic brain injury. Is anything being done to educate trainees, such as law students, medical residents, etc., here in Manitoba to become educated about this issue? If not, is there something that could be developed that would, I guess, would help those working in this area?
So I don't think there's anything formal right now. I think Dr. Ellis and I do some little pockets of education when asked, but is there a platform to develop something? I think absolutely. I think there's a ton of service providers that could utilize the information, but there's nothing formally in place right now that I'm aware of.
I would agree with Ashley. I think when it comes down to frontline service providers, I don't think service providers need a whole lot of information. I think they need some basic information about this intersection, some information about the signs and symptoms, and how these types of injuries can present in the clients that they would encounter. There, like I said, and it's posted in the chat, there's a great MAWS course that was developed by the Resolve research group and MAWS that people can use. There's the SOAR project, frontline service provider module. These provide some basic information about IPV and brain injury. And then, but obviously, as Ashley and I have kind of touched on, there's a lot of work that needs to be done in terms of educating a whole bunch of different healthcare providers on this intersection and how each one of those providers and what their role is in caring for this patient population, and how we can work together to create a more collaborative system of care for these patients in Manitoba.
Great, thank you. Another question, is there increased risk of dementia for people who have experienced intimate partner violence? That's a great question. So has that been looked at in terms of, I guess, increasing a person's risk of dementia if there is traumatic brain injury?
Not that I've ever seen in the literature, but I don't know if Dr. Ellis is aware of anything from other concussion or TBI literature.
There's definitely some literature that's trying to look at the association between concussion, traumatic brain injury, and repetitive head trauma in the early onset of mental health outcomes, cognitive impairment, and different types of neurodegenerative diseases, including different forms of dementia. I don't think, or I'm not aware of any studies that have looked specifically at the association between exposure to IPV and the development of those types of outcomes.
Thank you. Okay, I'm going to go back again to the chat. Okay. Hello, I'm the Justice Project Manager for Headway UK, the Brain Injury Association. I am delivering training to police and probation officers on intimate partner violence and brain injury in the next 6 months. I am interested in conducting a pilot study on the impact of perpetrators' awareness of brain injury. I have not been able to find any research on this topic. Is this something you would be interested in exploring? And, and that's a great question, because I think someone else had, maybe said something in the chat too about their experience, that this information can often be used by perpetrators to further control their abusive or their spouse, right? About, again, undermining their credibility to service providers or to law enforcement. So is there anything, have you come across anything about the impact of perpetrators' awareness?
I'm not aware of anything right now or anything in the literature at all.
I'm not aware of anything at all. I can speak to the first part of that question. I think since Ashley and I have sort of got to know each other, we've been involved in a lot of kind of educational initiatives across different types of sectors, giving talks to different frontline service providers such as shelter workers, lawyers, police officers. And so we've developed a bunch of different, I would say, like informal kind of presentations and things like that in services that for those different different stakeholder populations. So if you'd like to reach out to us, I'd be happy to share the information that we've shared across different sectors, just as kind of routine, informal educational initiatives. And again, I think whenever you're developing any type of educational tool, it really has to meet the needs of the stakeholders that you that you're interacting with. One of the things that we've sort of developed, we have a program where we do see patients who have sustained intimate partner violence related brain injuries in Nunavut. And so we've been able to develop some kind of recognition tools and protocols to assist healthcare providers in terms of kind of recognizing these injuries and things like that. A lot of these recognition tools just feature very simple questions, like, did your partner choke or strangle you? Were you hit on the head, or did they cause you to hit your head? Do you have these types of symptoms? And then just have a bit of a plan about what to do if a patient or a client screens positive for those types of things. We're not talking about diagnosis, but I think simple tools like that can be incorporated into teaching, so that different types of frontline stakeholders have a bit of a better awareness, and just a place to start when trying to recognize these injuries.
Thanks, Michael. Michael, we have a number of people who are asking about how to connect their clients with you. Is that something that they would have a family physician refer their patients to your clinic at the Pan Am Clinic?
So we didn't really go into too much discussion about what the clinical resources were, recognizing that the audience was going to be from a bunch of different provinces. So I'll speak a little bit to that. About 3 years ago, at the start of the COVID pandemic, Ashley and I kind of got together with leaders from the Emergency Department of Health Sciences Center to develop a bit of a pilot project about how we could begin caring for patients who had sustained these types of injuries. Probably across Canada, a lot of patients who sustain acute intimate partner violence related head trauma are probably seen in an emergency department or a primary care setting, like an urgent care center or a walk-in clinic. And oftentimes they're not provided any longitudinal follow-up care. Sometimes they're passed back to their primary care provider, who may not have much experience in brain injury. And we know that a significant proportion of patients may come from rural or remote communities where they may have difficulty accessing primary care providers or sometimes any form of medical care. So we developed this program where we began seeing patients from the Health Sciences Emergency Department who had acute injuries, were seen by the same program, and underwent a medical assessment through the emergency department. So we've been doing that for about 2 to 3 years now, and this has really been like a learning process for us. Across Canada, there's no other type of clinical pathway that we know of that operates this way, where an emergency department would be linked to a concussion program. And so this has led us to kind of develop a bit of a new framework of network or a network of providers who normally we don't send patients to in the sport-related world, such as plastic surgery, psychiatry, addictions medicine, those types of things. And so what our hope is that by developing this pilot project, we're starting learning more about this patient population and how to best care for them. Over time, we have been trying to expand this program. We're now receiving referrals from a couple of different clinics in Manitoba, such as Mount Carmel Clinic and Clinic with a K. We've expanded to St. Boniface General Hospital, and we're trying to also work with a couple of shelters to be able to receive direct referrals from those shelters, both Willow Place and Iqwe. But we're not at a stage now where we're able to receive referrals for patients all across, Canada in any way. We do have a program, like I said, where we do provide care for patients who are seen at a healthcare facility across Nunavut and then are referred to our program. It was originally limited to patients that were seen within the Kivlek region of Nunavut, but we've now expanded that to across Nunavut, recognizing that there is not a lot of multidisciplinary concussion programs that are providing specialized care to this patient population. Having said that, we also realize that there's a massive gap, and that it's very difficult to direct patients towards this type of care. So if there is concern about individuals and you have their consent, you can contact me and we can discuss things on a case-by-case basis. But right now, we do not have a funded provincial IPV traumatic brain injury program in Manitoba.
Thanks, Michael. Another question here. Can an MRI or other type of scan determine whether head injury can specify? Can an MRI determine when a head injury occurred or how long ago it started for a person who's experienced intimate partner violence and traumatic brain injury?
So as we sort of pointed out in our presentation, patients who sustain intimate partner violence, traumatic brain injuries, and head trauma very frequently are those that have been exposed to multiple episodes of previous head trauma in the setting of intimate partner violence. So it's very difficult sometimes to be able to quote unquote date a specific injury. A lot of the patients that we do see with acute intimate partner violence related head injury, even those with more severe injuries, have imaging that is grossly normal in terms of CT scanning. We can use MRI, which is more sensitive to traumatic findings, to identify whether or not a patient has had a structural traumatic brain injury. But it can, and sometimes based on the imaging features and characteristics of the signal within like blood products and things like that, you are able to maybe estimate when those injuries occurred. But in patients who have had remote injuries, like more than 6 to 12 months, it makes it a little bit difficult to be able to ascertain that a specific finding on an MRI is related to a specific incident of head trauma, especially in the setting of somebody that has had repetitive head trauma.
Thanks, Michael. Another question, perhaps for Ashley or yourself. Can you recommend any resources or literature on the potential impacts of traumatic brain injury on parenting capacity or any potential risk to children?
On parenting capacity and risk to children, I have not seen any yet. I don't know if Dr. Ellis has, but yeah, I don't think there's anything on risk to children or how that impacts parenting capacity at all.
I don't know of any literature that I don't know of any research literature that's examined that, or resources that could be given to patients or survivors, to be honest. I do think that this is an important gap. I think one of the things that we touched on very briefly is that very frequently there are children that have been in households where they've been exposed to intimate partner violence, and those that have directly been exposed in the sense that they've witnessed these types of incidents. I think that as we start to develop more comprehensive clinical programs, we also will have to find ways to be able to identify the impacts that this has had on children and families and provide them supportive resources as well.
And I think that question might be based on this fear that if traumatic brain injury is identified and is, brought into court, will that be used to maybe a potential evidence that survivors might not be able to care for their children, or not, might not be able to parent or have some type of deficiency in their parenting. So maybe I'm not sure if that's where that question is coming from. So I think that is it for the questions. I do want to open it up to you, Ashley and Michael. Are there questions that you have for our audience that you are curious? As you could see in the poll, there's a variety of kind of professions represented here. I think, one group that we didn't include is the general public. I think, many of whom I think are survivors who are joining in on this Zoom call, which I think is great. But is there anything that you want to ask the participants?
A question that I would have is, as a physician, how can I do a better job of preparing my patients to kind of navigate, the family court system? And how can I do a better job of just kind of supporting them as they navigate that system?
And I guess I could just maybe encourage people to write something in the chat or the Q&A as a response to that. Ashley, do you have anything that you'd like to add?
I don't think right now. I've really enjoyed reading a lot of the chat and the Q&A. I think a lot of the perspectives people have given, and I'm extremely appreciative of survivors and people who have lived experiences who have provided that as well, because I think that helps us all as providers. But I don't think I have any other specific questions, but I want to thank everyone for their feedback.
Okay, I'm going to go in and just make sure, see if people have responded to that. But maybe you can just answer another question that we have from Resolve, is that can you maybe just discuss what the recovery process looks like for survivors of violence who have traumatic brain injuries?
I think I can touch a little bit on that. As I said, we've been seeing patients for about 3 years now. So my comments on this based on personal experience is pretty limited. I mentioned before that there's not a lot of research that looks at clinical outcomes in patients that have had intimate partner violence related brain injuries. I do believe that patients who sustain traumatic brain injuries in the setting of intimate partner violence, if they do receive the timely medical care that they need, can experience resolution of their symptoms related to traumatic brain injury and concussion. But oftentimes when patients' concussion symptoms improve, it's at that time that they can start to identify some of the mental health impacts of the injuries that they sustained either recently, previously, or historically. So one of the biggest gaps in care and challenges for us is trying to connect our patients to kind of longitudinal mental health services like counseling and things like that to help work through that sort of long-term process of healing from multiple forms of trauma.
Thanks, Michael. Just in response to your question, I know there's a lot of people who are putting responses in, but one suggested, being an expert, providing expert testimony. Has that something that you've done in family court?
I'm have an expert I'm doing in British Columbia right now for a class action. So it is something I do from time to time. And in Manitoba, I have on strangulation. So I think that's something both Dr. Ellis and I would definitely do, but we have to be asked to be an expert witness in court. But if that was something that was beneficial to a case, depending on what the area of expertise and the opinion that's sought, I think one of us would be happy to do that.
And just some more responses to that. Well, thank you for that, Ashley. Really being an advocate for women, participants are saying taking the time that patients need. So, having physicians spend time with their patients to identify and discuss these issues, providing, I guess, education to the legal community, to the public, and I guess believing survivors and their stories. So those are just some of the responses in the Q&A. I will move over to the chat. Many people are just giving lots of a lot of thank yous, saying it's great information. Let me just see here. Okay, to Dr. Ellis, from my perspective as a family lawyer, it may be helpful to empower patients or provide them with the language, either written or coaching them to share verbally with their lawyer to share potential symptoms. And I think this kind of gets at the question that I asked earlier. So any more thoughts on that? So what kind of language that we can, provide to family lawyers or their clients about this?
I think a lot of times patients are experiencing different types of symptoms that they don't always have the language to describe. A lot of the symptoms that we see among patients may just be different things, where a patient says, I just feel slow, or I just don't feel like myself, or those types of things. Sometimes too, if a patient has lived a life where they have been exposed to repeated instances of trauma and head injuries, what the symptoms that they are experiencing are kind of part of their normal life, and they may not view those as significantly worrisome kind of or new features. So there are a lot of resources. I was trying to find them online to be able to provide people. We were able during the COVID pandemic to host a bit of a summit on intimate partner violence, traumatic brain injury. And as a part of that, we were able to develop some key resources that provide some background on intimate partner violence related brain injury, both for frontline service providers and then also a post-injury education sheet. So I'll make sure to share those with Kendra just so that they can be kind of available to the attendees. But I think oftentimes too, I think my experience a lot is that I haven't had a lot of patients that have had to kind of navigate family court, or at least they haven't shared details of that experience with me. But if there's ways of us being able to better prepare our patients about, how they're experiencing things, what we see as maybe some of the impacts of their symptoms on their daily lives, and if there's literature or resources that we can either I can review or you can look to co-develop with us, we would always be interested in that for sure.
Great, thanks, Michael. I've posted Ashley's and Michael's contact information in the Q&A. So please look for that. Just some more comments in the chat. We have opened a strangulation clinic in Surrey, BC, and are happy to provide support for starting more of these types of clinics in Canada. Just like Ashley and Michael, we saw the need for specialized focused care beyond just a forensic exam. We also provide follow-up medical care to all survivors of recent violence. Okay, important for first responding healthcare providers to document injury in detail, even if it appears minor, so that someone with expertise in these injuries can speak to them in court if needed. Ashley, do you want to maybe say anything more about documentation?
For sure. I think it depends on the jurisdiction you're working in and what documentation is available. I can say in the services I've worked with in Manitoba and a lot of forensic nursing services I know across Canada and the US, any injury, any symptom is usually documented quite well. So however major or minor that may seem, and that's why we ask a lot of the questions we do, and that's why we really encourage survivors, even if they think their injuries are minor or that they don't have any injuries, to come in and seek that care, because there may be things they might not think are a result of the strangulation or the injury to their head. I think it's really important though for other healthcare providers as well to document anything that they're noting in patients and to do a really good complete history. But if you have forensic nursing services available in your area, they usually are very well trained to be able to provide that documentation. And then if somebody is going through the court process, even if they've not involved police, when they went to hospital, that documentation can usually be subpoenaed or can be acquired, for those purposes if that survivor and that attorney wants.
Great, thanks, Ashley. I think that is about it for the Q&A and the chat. I'm going to put my camera here. Just so many people thanking you both for the presentation. I think it was an excellent presentation. I'm just delighted to have both of you. You can just tell by the questions that this information is so needed by so many sectors. So again, I just want to thank both of you for an excellent presentation. I want to thank, of course, those who are involved on our end making this webinar possible. Again, to our funders, to Ashley for facilitating this, for organizing it, for Patricia helping out with the webinar piece, and of course, the IT support that we received from the University of Manitoba. So thank you. And of course, thank you so much to everyone who attended today's webinar. We will make it available on the Resolve website, and perhaps we can go, Patricia, if you can put back the PowerPoint slide and I can walk through that. You just go down to the bottom again, to the dots. Yeah. So again, we value everybody's feedback. We do host a couple of webinars a year. We will be hosting another one probably late spring, and then another one in the fall. So we value your feedback. So please take the time to complete the survey. Next slide. And again, just want to let you know that today's webinar is based on the project that we're doing with the Alliance of Canadian Research Centres. So Resolve is one of 5 research centres on gender-based violence across the country. We were directly created out of, or a direct result out of the Montreal Massacre in 1989. And so we're working on lots of projects. We have a number of webinars that we've done for this project relating to intimate partner violence and family court. You can access past webinar recordings and PowerPoint presentations, as well as briefs linked to these webinars, and all are available in both French and English. So please feel free to access the Alliance website for all of this information. And of course, if you want more information about this study, you can contact myself, and we have listed my contact email here. Next slide. For those of you who are registered social workers in Manitoba, you are able to use or claim this webinar towards your continuing competence program credits. And please click on that link if you have more details, for more details. And next slide. So please stay connected with us. We are on social media. I have our email here, as well as the Resolve website. We will be posting the recording also on the Resolve webinar, in addition to the Alliance website. And of course, we have information about all the other studies that Resolve is involved in as well. So I just want to say thank you again to the presenters. I'm having more chat come in saying how excellent the presentation was. So again, many thanks to everyone, and I guess stay tuned for upcoming webinars and upcoming information from Resolve. So that concludes our presentation for today. Thanks, everyone.